Good morning, Mr. Jones. My name is Ashley. I'm going to be your nurse today. I'm going to be assessing your thorax and your lungs. If you have any questions along the way, please let me know. For privacy reasons, we're going to leave your shirt on, but normally I would have you take your shirt off. So to start out, I'm just going to, if you'll just breathe normally, I'm just going to look to see if you have any pursed lip breathing or nasal flaring, which could indicate respiratory distress, COPD, or some congestive heart failure, CHF. I'm going to look at the color of your face, lips, and your chest to look for any purple or ruddiness, which could be COPD or CHF again, or any cyanosis that could indicate hypoxia. And you're nice and pink. Next, I'm going to look at the nail beds to look at the color and the shape. His are nice and pink and normal. There's no clubbing or cyanosis, which could indicate hypoxia. Next, I just want to, as Mr. Jones breathes normally, I'm going to look at the shape of his chest. I'm going to look at the rate, the ease, and the pattern of his breathing. He's breathing at a nice normal rate with ease. There's no retractions. Any kind of abnormal patterns would be like hypoventilation, hyperventilation, or Cheyenne-Stokes. Like I said, he has no retractions. His chest is a nice normal shape. He doesn't have any barrel chest. I'm going to look at his sternum on the front of his chest. His is nice and flat and straight. He doesn't have a pigeon or funnel chest. On his posterior thorax, I'm going to look at his spine and make sure that it's nice and midline, that he doesn't have any signs of scoliosis. Again, I'm going to look at the shape, and he has no barrel chest signs. He is sitting nice and upright. He's not using any accessory muscles such as his neck or his trapezius or anything like that to aid his breathing, which could indicate respiratory distress. He's also, like I said, sitting upright. He's not in the tripod position, which would be respiratory distress or COPD. Next, we're going to palpate. As I'm palpating the posterior of his chest, I'm going to be checking for any pain, tenderness, warmth, crepitus, which is the crackling feeling under the skin due to trapped air. And I'm also going to be checking for any masses or lesions. The pain or tenderness could be due to something as simple as just muscle soreness from exercise, excessive work of breathing. It could be inflamed pleura or fractures. The warmth could be due to a local infection, which all that feels normal for him. So next I'm going to check the fremitus. So as I palpate with the ball of my hand, Mr. Jones, if you could say 99 for me.
99, 99, 99, 99, 99, 99, 99, 99.
What I'm checking for
99
is the vibration
99, 99,
and the intensity.
99.
I want to make sure that everything
99.
is equal.
99.
Any unequalness or diminished vibrations could be due to consolidation or obstruction, which all of that feels normal for him. So next we're going to percuss. Well, before I do that, I'm going to look at his chest expansion. So as I'm going to place my hands in this position on his back. On the posterior, I'm going to place my hands about the T9, T10 level. And as Mr. Jones takes a deep breath in and out, I'm going to watch my thumb movement and make sure that it moves in an equal position. And his does. Any unequal movement could be due to chest trauma, a pneumothorax or pneumonia. And also diminished movement could be due to decreased diaphragmatic function, which is related to COPD. So now we're going to percuss his chest. I'm going to start with the posterior. So as I'm percussing, what I'm checking for is to hear that normal resonant sound that you should hear over the normal lung fields. I shouldn't hear any hyperresonance or dullness in the lung fields. Dullness could be due to fluid or tissue that's in the lung space, which could be a pleural effusion or a tumor. So all that sounds good. So the last thing with percussion is we're going to check the diaphragmatic excursion. So Mr. Jones, what I'm going to have you do is first you're going to exhale forcefully for me, and I need you to hold your breath as you do that. All right. So as he's holding his breath, I'm going to percuss downward and check for that resonance to turn to dullness, and I'm going to mark that spot. And now, Mr. Jones, if you could inhale for me and then hold your breath. And I'm going to percuss down from that first mark spot and check for the resonance to also turn to dullness. And you can breathe normally, Mr. Jones. I want to measure the distance between those two marks. And his is about 4 centimeters. I would repeat the same on the other side of his back and compare the measurements. You want them to be close or pretty equal. If it's unequal, then it could be due to something like unilateral pneumonia. So the last part of our assessment is going to be auscultation. So as I listen to each part of Mr. Jones's lung fields, I'm going to have him breathe normally in and out of his mouth. I want to listen to the whole respiratory cycle to check for any abnormalities. I wouldn't usually listen through the clothing, but for privacy reasons, for this assessment, I'm going to. So Mr. Jones, if you could just breathe in and out for me. Mr. Jones has very nice and equal, clear breath sounds. What I was listening for to make sure is that he didn't have any abnormal breath sounds, which could be either diminished, absent, or unequal breath sounds. Some other abnormalities could be if he had wheezing or crackles or stridor or pleural fiction rub. So those are some abnormal breath sounds that you could potentially hear. Also, if I wanted to assess the voice sounds, I could have Mr. Jones, as I was auscultating, say 99, the letter E, or whisper 1, 2, 3 to check for any abnormalities with those. But he sounds nice and normal and has a good lung function. So that completes my assessment, Mr. Jones. Do you have any questions about anything? Well, I really appreciate your cooperation and your time today, and I hope you have a great day.